So a very warm welcome to everyone joining the Fragile X FMR1 Premutation update webinar with Dr. Jonathan Cohen. So we've got a high number of registrations for this webinar, so clearly we're all very interested to learn more about the premutation. So this webinar was planned after Jonathan and I attended the International FMR1 Premutation Research Conference, which was held in New Zealand last year. And for the first time, presentations were included by the lived experience community, so us as carriers of the FMR1 premutation gene change. So both Fragile X Australia Association board member Karen Lipworth and I presented surveys sharing the voice of the Fragile X premutation carriers. Dr. Jonathan Cohen also presented as a researcher, a Fragile X family member, and a GP with extensive experience and knowledge of the premutation. So as a person living with the premutation, I have to say the amount of research and new information emerging about the premutation was amazing. My overall takeaway was that we know more than has ever been known about the premutation, but there is still much more to learn and understand. So there's a couple of things I'd like to share with you before Jonathan Cohen's presentation, because I think they give us some context to the information he'll share. The concept of at increased risk of compared to the general population was widely discussed as a way to share what is currently known about the impacts associated with the premutation. And so talking about these possible effects and or conditions as risk factors takes into account that there is still unknown elements, including the difference between males and females, the impact of CGG sizes, activation ratio, FMRP, the protein levels, AGG interrupters, and environmental factors. So discussing the possible effects of the premutation as elevated risk factors, as opposed to labelling conditions, was recognised as an approach which better embraces our current knowledge base. And it also gives us positive pathways and information to manage and care for our health and well-being as premutation carriers. So it was widely recognised the language used to describe the emerging knowledge was important also. And the term Fragile X Premutation Associated Conditions, so FXPAC, you may have heard of, is now used as an umbrella term following the conference. So the conditions FXPOI, FXTAS, and FXAND, alongside other possible health and well-being factors, now sit under the FXPAC umbrella. So this presentation is an update and overview of what's current knowledge and thinking about the premutation. So we won't go into great depth on specific conditions like FXTAS or FXPOI, but please note that there is an upcoming conference about FXTAS specifically, and an excellent webinar recording on FXPOI on the Fragile X Association of Australia's YouTube channel by Dr. Amanda Vincent called FXPOI, What Do I Need to Know? I'm going to hand over to Jonathan to introduce himself, as I know he is known to many or most of you here. But I'd just like to add how fortunate I think we are to have Jonathan sharing this information. Personally, he's one of my favourite people in the Fragile X world, and I really value his balanced approach, both based on both his clinical experience as a GP, his long involvement in research, his lived experience as a family member, and his commitment to positive change in the Fragile X world. He was an important ally to both Karen and I at the International Premutation Conference, which enabled us to have meaningful impact with researchers. So he's the real deal, and I know he is widely respected internationally and in both New Zealand and Australia. So over to you, Jonathan.
Well, thanks very much, everybody, for joining us tonight for this update on the FMR1 premutation. And I want to thank Wendy, the Fragile X Association of Australia, and Andrea, the Fragile X Society of New Zealand, for putting this together. This is what we'll be talking about tonight. So the FMR1 premutation stands for the Fragile X messenger ribonucleoprotein 1 gene, FMR1 gene, and we'll be speaking about the premutation-associated conditions, FXPAC, Fragile X premutation-associated conditions, not Fragile X syndrome, which are dealt with in other webinars. The FXPAC consists of a number of different conditions, some of which you will all be familiar with, and we'll be speaking about each one of these in this session, but concentrating on FXAND, the Fragile X Associated Neuropsychiatric Disorders. We'll spend a little bit of time on each of these, on testing and screening, and finishing off with overall comments on managing a healthy lifestyle, and that'll be followed by a question and answer session. Fragile X associated conditions are divided into Fragile X syndrome and the Fragile X premutation associated conditions known as FXPAC. We'll be concentrating on FXPAC, and you can see the boxes here on the left are divided into Fragile X associated neuropsychiatric disorders, Fragile X primary ovarian insufficiency, and Fragile X Tremor Ataxia syndrome. There's also a group of other conditions, and we'll be moving through each of these through the session. Much of the information that I'll be presenting is a result of an article that was written by these 60 people who attended a conference specific to the FMR1 premutation in New Zealand last year, 2023. And they came up with this massive article, and I've put the reference up there for those of you. So it's about 70 pages. There are 46 authors. I've circled some of them who you may recognise, including Andrea Lee from the Fragile X New Zealand Society. Go back to a summary of Biology 101. Every cell in the body has a set of chromosomes which we inherit from each of our parents. If you unwind those chromosomes, it's simply a long double helix strand of DNA, which are repeating molecules. In the case of Fragile X, the molecules of interest are cytosine, guanine, guanine, or CGG, triplet molecules which repeat over and over again. For those women who carry the premutation or the CGG repeats, they're at risk of that repeat zone expanding into a longer mutation, or a longer variation is the new word for mutation, and having a child affected with Fragile X syndrome. So if we look at the actual numbers, you can see that the average neurotypical person has less than 44 repeats. The premutation is between 55 and 200 repeats, and above 200 repeats, the person has a full mutation and it will be affected by Fragile X syndrome. In this session, we'll be talking about people with a premutation, the FMR1 premutation, which is an expansion between 55 and 200 repeats. Of interest is the AGG molecule, which, if it is present more than once or twice in that expansion, makes it more stable and less likely to expand into the full mutation. And if we look at this graph, you can see that, for example, somebody who has 65 repeats, if they've got 2 AGG interrupts, they're very unlikely, that gene is very unlikely to expand in the next generation. The premutation can have effects across the lifespan, and this is a slide from that paper, which is really spearheaded by Flora Tassoni, Rondi Hageman, and it's showing that in early childhood we can see learning disabilities, social difficulties, some behavioural issues such as anxiety, ADHD. In young adulthood, and with females, we can see the ovarian insufficiency begin to occur. And then through adulthood, really through adolescence and adulthood and onwards, we see the behavioural and emotional side, the FXAND, which is a term coined by Rhonda Hageman in 2018, and then later in life, the Tremor Ataxia syndrome. So starting off with the Fragile X Associated Neuropsychiatric Disorders, FXAND, these terms, disorders, are put together by the American Psychiatric Association in a publication that's reviewed quite regularly called the Diagnostic and Statistical Manual of Mental Disorders, DSM-5, they're up to now, gets upgraded every few years. And they set various criteria for a psychiatric disorder. The terms used are anxiety disorders, depression, obsessive compulsive disorder, OCD, ADHD, attention deficit, hyperactivity disorder, and autism spectrum disorder, ASD. And there are specific criteria in order for each of these terms to meet the term disorder. Now, when Rhonda Hageman published this in 2018, it all made sense because a lot of people were turning up to their clinicians and saying, look, I've got all of these symptoms. What's wrong? Why am I feeling this way? What have I got? And very clearly, people who said what is happening here can be diagnosed and were diagnosed as having a disorder. A couple of years later, a group from Europe published a paper saying, look, we don't like the word disorders. We want to use the word conditions, hence FXPAC, Fragile X Premutation Associated Conditions. And as you'll see through this presentation, some people have disorders, some people have conditions, and some people don't. And we'll spend a bit of time teasing that out and hopefully explaining that a little bit better. So to meet the criteria for a DSM clinical diagnosis of an anxiety disorder, the symptoms need to have three of the following. So the anxiety needs to be excessive. It's not just, oh, I'm worried I might not have petrol for my car. This is ongoing anxiety and worrying about things that is present for a long time, at least 6 months. It's affecting people's relationships, their ability or their interest to interact with others, or affecting their ability at work or at school if they're younger. And the person finds it difficult to get on top of. So there are 3 or more conditions: restlessness, feeling unusually tired, more than you would expect for all of the time, pretty much every day, difficulty concentrating, being irritable, muscle tension, and disturbed sleep, either too much sleep, just wanting to sleep a lot, or waking up early is a very typical, waking up in the middle of the night, not being able to get back to sleep because of worry. And if 3 of these are present, then the person meets the criteria for having an anxiety disorder. Now, some of you might be thinking, well, you know, I've got that, or I'm living with someone who's got all of those, and they may very well meet those criteria. And we'll talk about management shortly. But there are a lot of people who are just perhaps restless or feeling a bit hyped up and are a bit tired, and that's been going on for a long time. So if you've only got 2 of these symptoms, then you don't meet the criteria, and we use the term subclinical or subthreshold for that. So you actually don't have a disorder, but you certainly know that something's going on. And there's the whole spectrum from having nothing through to having the whole lot. And that's the job of a clinical psychologist or a psychiatrist or a good GP to interview the person and tease that out. And it's got implications for how things are managed. So anxiety is a common condition. It's felt by 10% of the population overall. And there are a number of studies which have come out which show that in the premutation carriers, FMR1 carriers, it's around 30 to 40%. So that's around 3 to 4 times what we see in the general population. There are a number of people who have, number of colleagues, a small number, who have questioned whether the gene is an actual cause or an association, whether it's a direct cause or it's an association. But certainly the studies of known carriers confirm that the incidence of anxiety is higher than for most people. Now, it's not everybody who's a carrier has anxiety. Obviously, it's 30 to 40%. The question is raised about what about people in the general population that don't have a family with Fragile X? What's that incidence? And we don't have that information at this time. Anxieties can be divided into different types, so generalized, just generalized anxiety, specific fears about one thing, social anxiety, being anxious about going into a social situation, obsessive compulsive disorder. You know, somebody who is an avid stamp collector, you might say, has obsessive compulsive disorder, but it's restricted to just one thing. They wouldn't fit that criteria. It would be somebody who is really not able to function because they can't get the stamp that they want, and that's been going on for 6 months. So there's certainly a way of teasing out whether somebody has a disorder or a difficulty from their anxiety, or whether it's just an intense interest. Panic disorder is another one, and we see depression quite often in people with anxiety, and vice versa. People with depression, we often see anxiety present. So for females with the premutation, a lot of our patients that I see tell me that they'd always had anxieties being present since they could remember. So it's well prior to learning about Fragile X and going on the internet and saying, oh, anxiety is common, I must have it. It had always been present, or has often been present. And the other issue of having children, of course, alone, any children with or without Fragile X can raise anxiety. But these are people who can describe always being anxious. The incidence of anxiety increases with age. So as people get older, we tend to see more anxiety, and it is obviously can be associated with a reduced quality of life. Regardless of what the cause is of anxiety, whether it's from Fragile X gene or not, the management is the same. So the Royal Australian New Zealand College of Psychiatrists recommend a personalised approach tailored for each person, and going through lifestyle changes, exercise, diet, limiting drug and alcohol, smoking, all of those things which I'm sure everybody knows about, but actually implementing them is one of the best things for people to do. The other interesting thing about the guidelines, and it's available online, if you want to go looking, just put in RANZCP anxiety guidelines, and there's some great information in there, is that the recommendations are first-line treatment can be either with cognitive behavioural therapy, which is a psychological technique that's used of learning to be aware about anxiety, what causes it and how to manage it, or medications, and specifically SSRIs, SNRIs, the selective serotonin reuptake inhibitors or the serotonin noradrenaline reuptake inhibitors, or both. So the first line management after lifestyle changes can be either CBT, medications, or both. Depression, which is lowered mood, also affects up to 10% of the general population, and we also see an increased incidence in carriers, and specifically female carriers, more than male carriers of the premutation. And that can be either major depressive disorder or bipolar disorder. The bipolar disorder implies that there's been at least one episode of manic behaviour, which is, you know, constant, ongoing hyper-arousal behaviour, staying up all night, literally going on all of the time. So if there's been one episode of that, the diagnosis may very well be bipolar. The symptoms of depression are lowered mood is the key one, being irritable, overtired, not being interested in things, again, impaired sleep, not functioning well, and again, anxiety is often there as well. And we see the incidence higher of these depressive symptoms at around 30 to 40%. It's difficult to measure depression other than asking someone, how do you feel, and asking about symptoms. there isn't a blood marker, there isn't a biological marker to measure depression, and it's confounded by, you know, if you're busy at work, you've got work stress, you've got kids giving you a hard time, you're in a bad weather environment, and you've got other genes that can also be additive. And a lot of this information about whether the gene causes anxiety or causes depression remains to be elucidated, other than to say there's clearly an association. Once again, management of depression is the same as of anxiety, lifestyle changes, again, CBT, which can be face-to-face or online. So there's a number of websites, including Beyond Blue and Black Dog Institute, that actually offer counselling online with techniques that you can do yourself or people that you can talk to, a lot of which is funded. So there's no cost for that. My personal view is face-to-face is the best for a lot of reasons, but if that's not practical, then there's online, both funded by government or through Medicare or private health insurance rebates with a private psychologist. Medications, again, there's a whole range for depression. It's not just the SSRIs, SNRIs, there's also mood stabilizers and medications that affect the melatonin system. The older tricyclic antidepressants can be very helpful. And the newer atypical antipsychotics, terrible term, you don't have to be psychotic, out of touch with reality. They happen to have a great effect on anxiety, and they can be very helpful for a lot of people. Now, most people can manage anxiety and depression themselves, but it's best in consultation with a good GP and or psychologist and or psychiatrist. So this is a paper from that we published a couple of years ago with Claudine Crown, showing that the Australian Bureau of Statistics, about 7% have a lifetime diagnosis of, so somewhere through their life they've had depression, and anxiety about 17%. And in black, the LDS with females, 30%, so it's really 4 times compared to the average population in Australia, lifetime diagnosis and current symptoms, and with anxiety about 37%. Interestingly, in this group of about 140 women with the premutation, symptoms of anxiety were described at 70%, and that mirrors a lot of other studies in people with the premutation. So moving on to autism spectrum disorder, which is present in some FMR1 carriers, and the definition of autism is the key is the persistent deficits in social communication and social interaction. They say or do the wrong thing because they don't necessarily understand the social situation, which occurs across multiple contexts. I'm not just talking about someone who says something inappropriate at work or who doesn't say something at work, but also at home and outdoors or a dinner party, social situation. And the other side is restricted repetitive behaviours. And so you can see why a lot of people with Fragile X syndrome fit these criteria. But it's actually been missed a lot in females in the general population. And we're beginning to realise that there's a subgroup, a percentage, a small percentage of female carriers who have this. They've got good verbal skills, but the social use of it, the use of language in social situations is a little bit different. And that's called a pragmatic language differences. It's not a disorder. It's not a condition. It's just, it's a way that people use language, but it can cause ongoing and lifelong difficulties if not recognised. And so there's a lot of work that's being done by some of the younger American researchers looking into speech and the way that people interact. And this, of course, can affect the interaction from the parent to the child. ADHD, attention deficit hyperactivity disorder, can be just the attention side without anything else, like concentrating, difficulty staying on task, or hyperactivity, which is the motor side. These are the people that are constantly on the go, perhaps constantly talking non-stop. You can't get a word in edgeways, or both. And again, on DSM-5, the criteria for a clinical diagnosis, you need 3 of the following. So people who, you see this a lot in students, maybe not so much in adults, but it's certainly present in adults. People who don't pay close attention to details, making mistakes, moving around from topic to topic, not listening, difficulty organising tasks, reluctant to do things that require a lot of mental effort, easily distracted and often forgetful. So 3 of these things would meet the criteria. Doesn't mean that they necessarily need medications, but there are many, many strategies to help people manage their lives better by simply organising themselves and being aware of a tendency to perhaps lose attention. And just a word on executive function, which is, I think, a key issue that we see in premutation, especially in females, is summarised by planning and organisation, strategizing, working out what to do next, attention to detail, time management. And these things can be measured. And these things, executive function, is often difficult to detect without actually being aware of it. And we see this a lot in some very intelligent people. And as an aside, and I haven't put a slide on this, but there are some studies that have showed that the premutation females are actually higher intelligence, higher IQ. You can be academically and cognitively very clever, very smart, but if you have difficulties with organisation, it can mess things up a bit for you at home and at work and again in social situations. So a lot of FMR1 carriers have worked out ways to help themselves organise their lives. They make lists. They use, I mean, a lot of us do this anyway. I use Outlook on my phone and at work to keep my day organised. And so these sorts of tools can make a huge difference to people. And I think we see this as being a big feature, especially in the FMR1 females. So to answer the question as to whether people in the general population who are carriers are affected, there was this study that came out a few years ago, which is they got 20,000 people and they knew their genetic status, and they found 100 people who were carriers. Now, these people did not know they had the gene, so there's no confusion there. They looked through their medical records, which they could do electronically, and they found, for example, that there were much higher incidence, and this is a log scale. So anxiety disorders, chronic pain was much higher in females with a premutation. Infertility, again, the Fragile X primary ovarian insufficiency, and later on fractures, which may be related to the early menopause or ovarian insufficiency with inadequate estrogen, and so lower bone mass. And similarly with males with a premutation, we saw a lot of mood disorders, or we see a lot of mood disorders through here. So these are people that are not aware of their genetic status, and it's a very strong paper giving credence to the issue of increased incidence of these conditions in people with the premutation. It is only 100 people, so there's going to need to be a lot more work done in this area to answer that question. And just to apologise for a very busy slide on clinical involvement in children. The majority of children appear to be unaffected. We hear parent reports of behaviour and emotional issues. However, there is a subgroup, there's a percentage of kids who do have sensory challenges, anxiety, ADHD, all of these things that we've been discussing. And very often we hear about, specifically in females, especially in females, specific learning difficulties such as maths. And some of you will be nodding your head. We don't have enough studies with large numbers of people to underline this, but we're certainly all very aware of that. And there's certainly a percentage of people in their childhood, already affected in their childhood with these emotional and academic issues. And as I mentioned before, many are subclinical, so they don't have a formal diagnosis of a disorder, but there's certainly issues that parents and teachers are aware of. It's important for clinicians, if there are any clinicians watching this, to be aware of this, both clinical and subclinical presentations, because even something subtle can adversely affect learning and later on a person's behaviour and emotional life. For that reason, any child with the premutation needs to be offered an individualised assessment, so formal academic assessment and a formal behavioural and emotional assessment early on, so that the appropriate treatment and management strategies can be put in and get the best outcome. And the last thing to say about kids and adolescents and adults is that the gene premutation may not be the only gene that's in there. We know that people carry thousands and thousands of genes, and that the FMR1 gene certainly has some effect, but there may be other genes. There are other genes that will be causing other effects, both good and bad. And we're now in the position where if a child comes in with a developmental delay or significant learning difficulties, behavioural difficulties, not only should they be tested for Fragile X, but they can get what's called a microarray, which looks for a whole lot of other well-known conditions. And if needed, under Medicare, if they're under the age of 10, whole exome or whole genome sequencing, so looking at the whole gene. And that's bringing a lot of new information out, which the clinicians are needing to absorb and work with. So let's move on from FXAND to FXPOI, the primary ovarian insufficiency. So FXPOI is a condition that means that the ovaries stop functioning. This can lead to early menopause, infertility, and it's estimated that around 20% of female FMR1 carriers may develop FXPOI. So primary ovarian insufficiency, the definition is irregular or absent periods for more than 4 months, or absent periods prior to the age of 40 years. So if your periods stop at the age of 45, that's not premature, it's not primary, that's normal. FXPOI is POI, ovarian insufficiency, if you carry the FMR1 premutation. So the diagnosis is irregular or absent periods prior to the age of 40. You can get a blood test done to look for follicle stimulating hormone, which will go up as it tries to stimulate the ovaries to push out more estrogen. And there are a lot of well-known symptoms around the menopause, such as flushing, night sweats, and vaginal dryness, infertility, not always present. The risk of FXPOI increases for carriers who carry between 70 and 90 repeats. And if there's a family history of early menopause or any Fragile X syndrome or associated condition, then your suspicion would go up. So it's not uncommon for somebody with infertility to be going to an IVF clinic and they get tested, found to be a carrier, and then their sisters and other family members get tested and found to be carriers. The management of FXPOI is, because the ovaries switch down and then switch off, hormone replacement therapy needs to be put in pretty early. So I didn't put a slide in on this, but out of the 20% of female carriers who get ovarian insufficiency, out of that 20%, 1/3 are under the age of 30. Now that it's common for people to start having kids, start thinking about having kids in their 30s, that means a carrier needs to be detected very early and either have kids early or get their eggs frozen. If they're not producing estrogen, they need estrogen replacement therapy. Otherwise, there's a lot of negative effects on the cardiovascular system, the heart and the bone and other tissues. And so that's why HRT is really important, especially for younger people. Thyroid testing, so we often see low thyroid function, and I mentioned bone density as well. So these should be routinely done in people who are finding irregular periods or absent periods. If the GP is not familiar with all of this, then you can ask for referral to your preferred obstetrician gynecologist, in some cases a reproductive endocrinologist, and that would be more for IVF, in vitro fertilization. It's important to be aware of the FXAND conditions that we spoke about and other conditions such as migraine, fatigue, pain, and once again, sounding like a broken record, whole person care. So healthy lifestyle is incredibly important, and any good GP can give advice on preventive healthcare, including cardiovascular risk, cancer screening, and regular vaccinations. You can get in touch with the Fragile X Association of Australia or Fragile X Society of New Zealand, and there are a number of online support groups if you've got any issues or questions regarding FXPOI. It's recommended that people do have genetic counselling, either with a genetic counsellor, clinical geneticist, or a medical practitioner knowledgeable about FXPOI if you're carrying the premutation, specifically because of these risks. There is no argument, question or contention about the premutation being a direct cause of FXPOI. So here's a wonderful bar graph by Emily Allen at Emory, which was published 3 years ago, showing that this from 70 to really right up to here, 110 repeats. This is a group of women who developed FXPOI that's in green. And you can see, although the peak is between 70 and 90, there are still people who can get FXPOI right up to the high premutation and right down to 55 repeats. It might peak around here, but in this group of women, it was really across the age range. So moving on to Fragile X tremor ataxia syndrome. This is a progressive neurological disorder which presents with intention tremor and ataxia. Intention tremor is where you point towards something, and as you're trying to point, your finger starts to shake, or you're holding a cup of tea. So it's not a resting tremor. And ataxia is unsteadiness of gait, very poor balance, which can lead to falls. This condition is being looked at extensively, and it's thought that about 40% of men over the age of 50 will develop FXTAS, not necessarily full on, but it is progressive. So it can be mild, it can be severe, and a much lower percentage of women. In the early stages, it can be hard to pick. And not all tremor and not all balance is FXTAS. So it really needs accurate assessment by a knowledgeable neurologist over time. Specifically, an MRI, a magnetic resonant image scan of the brain, shows changes of the middle cerebral peduncle. It's like a whitish sign in this part of the brain, or else degeneration through other parts of the brain. And that's a very typical sign, although it's not always present. mentioned before, tremor, there's different sorts of tremor. The essential tremor is resting tremor. Intention is when the tremor comes up when you try to put your finger towards something. You may have heard of the finger nose test. The clinician will ask you to put a finger to your nose, then to their finger. And some people, actually present with something like Parkinson's, and they're beginning to see some similarities. But this is very, very specific condition, specific to males and some females who carry the premutation. So there are a whole lot of other conditions mentioned for Parkinsonism, which is difficulty moving and cognition issues, so difficulty understanding, memory problems. Neuropathy is where the loss of sensation in the nerves in the feet and or hands. Dysautonomia is the autonomic nervous system, so things that control blood pressure, for example. And these conditions may not be there, or they may be there in different degrees. Females, we see much less FXTAS, less balance problems, but we do see more tremor and more of the cognitive side. So a female, for example, 60-year-old with a premutation may start to develop anxiety. Now, there's no way to predict if this is going to become FXTAS, but it sometimes does progress further. So there's a wide spectrum of involvement, again, including subclinical, both the movement and the psychiatric side. There may be other genes that are playing into this as well. So there's certainly a lot of research going on in this area. FXTAS will be the subject of another webinar, which will be presented later next year, sorry. So the risk factors are, we see it increase with age, males, and as the CGG triplet repeat increases. And so once it gets very high, there's a lot more changes. If someone presents with tremor, that's the first sign, then they tend to be less affected with FXTAS. There's no way that we have to reverse or treat it, but it's thought that the protective factors, people on a healthy diet who are exercising, who have a higher educational level, and very low CGG repeats. So this was published by Mike Field and others a few years ago. And so the people with the very low repeats, below 70, so 50 to 70, 55 to 70, are very not likely, much less likely to get FXTAS. And of course, females are protected a little bit because they've got a second X chromosome. So depending on which X cuts in, and that's the X inactivation ratio, that can be protective. So we do see mild impairments begin years prior to the onset of FXTAS, but we don't have any predictors known as yet. There's a diagnostic table here, and it might be a little bit small to read, but a diagnosis of definite diagnosis of FXTAS would be the presence of one major radiological sign and one symptom. So if you've got a major symptom such as intention tremor or gait, and you've got the MCP sign, then that's FXTAS. So just a word about others. We've spoken about FXAND, FXPOI, FXTAS. There are a lot of other issues that people also experience, and these are a lot softer in terms of whether they're directly associated with the premutation, because they're so common in the general population. There's an awful lot of people with high blood pressure, and we don't have answers to this as yet, other than to say that these are reported a lot in people with the premutation. So you'll see on the Facebook listserv that people communicate on. People often complain about tiredness and pain, and fibromyalgia, which is a syndrome of pain across joints on both sides of the body and in the neck, sleep problems. And, it's difficult to tease this out because a lot of people have got these symptoms, but we do tend to see these a lot in people with the premutation. So a little bit about testing and screening. Cascade testing, which means looking for family members. If there's anyone in the past or present with a history of early menopause, known Fragile X syndrome, FXPOI or FXTAS, then family members who may carry the gene should be tested to see if they carry the premutation. The Royal Australian College of General Practitioners and the Royal Australian New Zealand College of Obstetricians and Gynecologists recommend all women of reproductive age be offered testing in early pregnancy for reproductive genetic carrier screening. So that would include Fragile X plus a number of other conditions. In Australia, November 2023, Medicare started to cover 3 conditions: the Fragile X premutation, cystic fibrosis, and spinal muscular atrophy. So any medical practitioner, GP or specialist can request those 3 conditions, and it's on Medicare. There's no cost. And that's done with the woman first, and then they'll do the male if need be. There are options for what's called expanded carrier screening, where you can screen for up to 1,200 genes, but there's a cost to that. So we're looking at close to $1,000+ for a couple to be screened for that. We spoke about AGG interruption earlier on in this presentation, and not all pathology providers do this as part of the Fragile X premutation testing. If they do, great. If not, and if you're needing that information to decide whether to go ahead with pregnancy or go through IVF, then the cost of that is $200 plus. Any woman experiencing ovarian insufficiency symptoms should be tested for the premutation, and the blood tests that GPs, obstetricians would generally do to assess that would be the follicle stimulating hormone, estrogen, and the anti-Müllerian hormone, which gives some measure of what's called ovarian reserve. In other words, is it likely that you've got eggs left that can be used? So a word on managing healthy lifestyle, and this comes from, every GP should be doing this, and every person should be discussing this with their GP. So I think we all know about diet and exercise. That's well known. Whether we do it or not is another issue. We discuss symptoms, past and family history with any person who comes in. It's important to have a physical examination once every 1 to 2 years, depending on your age. Assess cardiovascular risk. Includes weight, blood pressure, your cholesterol, triglycerides, sugar, cancer screening, skin check, bowel, breast, cervix, renal tract, routine vaccines, and routine blood tests, and if need be, X-rays, CT scans, ultrasounds. So this is important to do every year, more so if you carry any sort of medical condition, or if you're at risk of any medical condition. In this case, the female carriers especially, centering on but not restricted to ovarian insufficiency and FXAND, the emotional and behavioural side. So to conclude, we've spoken about FXPAC. We've spoken about that a subgroup of carriers are at risk of being affected. That means not all, that means a percentage, and that some of these conditions are in fact subclinical. In other words, they're very subtle, but they can still be significant and have significant effects on people's lifestyles and their health. It's important to be aware of all of these things so that you can put things into place early, rather than suffer through decades as some people do. So early detection allows treatment and management strategies to give you the best outcomes. Now, a lot of this information and more can be found in this article, or you're welcome to get in touch with me at any time. And following this presentation, we'll be having a question and answer session. Once again, thanks very much to the Fragile X Association of Australia and the Fragile X Society of New Zealand for allowing me to put this presentation together.